Thank you, Melinda, and hello, everybody at Northwestern. Yeah, I'm really excited to talk about this. As Dr. Ring said, I'm an expert in longevity, and where I work at WndrHLTH, we focus on what we call majoring in the majors. We focus on what we know to be true about what improves performance and health span, and that's the things like lifestyle, but really personalizing lifestyle around nutrition and sleep and exercise and making sure your brain is functioning as well as possible and doing brain training and all that. We don't do things like peptides and stem cells and cryo, which may or may not help. But a lot of our members or patients are doing them. And so I've done deep dives and I've consulted with the clinicians who are prescribing them for my patients so I know where they're getting them from. So I've learned a lot about this in the last couple of years. So I want to share that with y'all about the state of peptides. And so many of our patients in preventive care and proactive type medicine, personalized medicine are looking for these to see are they going to help them achieve their goals. So we're going to talk a little bit about what are peptides. I know some of you might be familiar with them, but some might not. So I don't want to assume anything. What are the research limitations? What are the clinical applications? And again, the reason it's front and center right now is you might have seen this New York Times articles or articles everywhere about peptides. All of our friends, probably all of us on this call or on this webinar, have been asked by someone, should I be doing peptides? I'll give you one quick example. I'm not even going to play the audio. You'll get a sense from the video. This is a TikTok video of someone who calls herself Dr. C or Dr. D, I think. Um, she has fashion posts and then she has peptide posts where she posts about injectable peptides. Some of them she has her vials right in front of her. She is actually not a doctor. She's not a PhD, an MD, or a nurse practitioner who's gotten her doctorate. She is just calling herself Dr. D and talking about these injectable peptides. So that's just an example for you to see of what we're facing in terms of the people that we are treating, hearing in the media. Dr. Ring and I were just talking about two people who died getting peptides at a longevity conference. Pretty ironic. And I don't mean to laugh, it's horrendous. And part of that is because these peptides are being blown up as the saving graces of anything related to aging, and yet they're not really approved by the FDA. In fact, in 2023 and 2024, there were rulings saying that you couldn't really manufacture them through a compounded pharmacy in the way that you previously could. So that has led to this kind of gray market, so to speak, of peptides being available from questionable sources. So everything we talk about peptides after this slide will be about what actually do peptides do if they are manufactured in a GMP type process and they are labeled correctly and they are the actual peptide, right? So just know that all of that science, which is really mostly animal studies, and I'm going to talk about that in a minute, but all of that is based on the actual peptide. But the first thing to be concerned about if you're working with a patient or advising even a friend is be careful where they're getting it from because there are a lot of disreputable sources. Um, so what are peptides? Peptides are basically just small chains of 25 or fewer amino acids. A few things get called peptides that have a little bit more than 25, but by and large are these small chains. And because they're so small, they mostly act as signaling molecules. So they're mostly not having their own effect directly. Sorry, I have a little cold, so I'll be wiping my nose every so often. But mostly they're signaling. Now that means they typically have less side effects because they're not taking over a whole process and exogenously elevating hormone levels, for example. Think of using growth hormone versus a peptide that stimulates growth hormone release. So you're working a little more with the body's natural pulsatile flow. That doesn't mean you're not having an influence that we don't really know the impact of in long term because we don't have long term studies. We have almost no studies in humans of a lot of these. But many of the peptides that we're hearing about in commonplace um, are ones that are fairly safe from what we can tell from the animal studies they've been done in. But peptides also include things like GLP-1s and insulin. So some of them are very proven. So I'll show you in a couple slides kind of the difference in quality of peptides in terms of the research and the ability to really know what they do. But the fundamental idea that distinguishes peptide therapy from traditional pharmacology is what you see on this slide. If you think of it like peptides are a little bit more of a dimmer switch, kind of upregulating or downregulating the flow of certain processes in the body based on attaching to a receptor and triggering some downstream processes as opposed to completely taking over a whole process. So it's kind of like in this example here, sulfonylurea that can cause hypoglycemia because it's really causing a lot of release of insulin by affecting the beta cells in the pancreas, as opposed to a GLP-1 that is an incretin that stimulates more insulin production endogenously. So it's a great way to think of how these work. That doesn't mean that they have no side effects. It doesn't mean they don't have long-term consequences, which we may not even know about, but it does mean that they have less side effects and they're taking over a process less kind of aggressively in a way. And remember, there are thousands of peptides. Many of them do decrease with age. That's why they're very prominent in this longevity space. About 500 are available for therapeutic use. And there are only about 60 that are actually FDA approved, and the evidence base varies widely. And what happened was basically in 2023-24, FDA guidance changed, as I said, and they released this updated guidance changing the rule around compounding pharmacies making them. So now, typically, you can only get a few that are actually FDA approved, like GLP-1s, like something called thymosin alpha 1 is approved for various viral treatments like hepatitis, so therefore it can be used off label. But many of them are not FDA approved, but they are being given, and your patients are getting them as research subjects. So the way a lot of these pharmacies have gotten around this regulatory landscape is by saying, well, we're only fulfilling orders because we're telling these clinicians are ordering them on behalf of patients that they are for research, and the clinician has to have a piece of paper saying they explain to the patient that this is for research only. So again, if you're prescribing them as a clinician, I'm not going to get too into the regulations that you should follow, but you need to talk to a lawyer and make sure you're documenting what your discussion is with the patient, that this isn't FDA approved, that it's been studied mostly in animals, that most of the data we're talking about are based on extrapolating from animal studies, and that this is officially for research only. So you'd have to work with someone who can advise you what exactly to document and make sure you do document that, but mostly making sure that they are being procured from a pharmacy that really is making them, like I said, in a GMP sort of way, even if they are saying it's for research only. And that's a gray zone. I'm not going to advise on that, whether you feel comfortable doing that or not. Some clinicians, I'll just say, are basically creating their own compounding capability, and the only peptides they use are ones they compound, which is probably the safest legally. But again, that's a hard thing to get started and rolled up. The big issue here, though, is the evidence kind of gap. And I want to say a few things before I get more into this. So, number one, is it really legal? It's a questionable area. Again, I want to spend the most of this time on the clinical use so you'll understand why people are even using them. So, that's a big question. The other big question is a lot of what I'm going to explain to you is based on animal studies or very few human studies. And I'm not going to talk about GLP-1s, those are obviously very studied. I'm talking about other peptides like the growth hormone peptides, thymosin peptides, the Wolverine stack, which is something called BPC 157 with TB 500, other thymosin ones, other ones that are for recovery, for longevity, for growth hormone, for building muscle, for mitochondrial health, one called MOTS-C. So I'm going to talk to you about the most common ones people are using and asking about. And almost all of these have very few human studies. And what we're doing in terms of dosing, those are who are prescribing it, is really extrapolating from animal models, which is a hard thing to do when you don't have the human studies. Sometimes just based on even like how do you extrapolate doses based on animal models? That's not really clear. And sometimes they're just using kind of body surface area of a mouse or a rat and extrapolating from that to a human. Um, the issue, though, is many of us who are on this webinar are doing what we do because we're on the leading edge of medicine. We want to be on the leading edge. We want to be able to work with things that would help our patients that might not have a full double-blind placebo randomized controlled trial, and yet seems to show some evidence. There's some clinical trials or some longer term longitudinal studies, maybe in this case just really good animal studies. They seem to have a good safety profile, and they do things that we don't have another way to get that thing done. So like recovery from surgery, from orthopedic surgery, like I'll talk about some of these peptides, or helping build lean muscle mass in someone who's losing lean muscle mass and has sarcopenia. or somebody who has immune system and is always getting sick, and some things that can augment what we do. However, you just have to realize that's where you're practicing. You're practicing at that leading edge where we don't have all that RCT data. And the issue with the peptides, the reason people are using them more and more, and these have been around for a long time, but they're using them more and more now, frankly, because the FDA is pretty broken. I'm not going to get political, but it is pretty broken right now. And so there is not a line of sight that any of these will become FDA approved. So I think that's why we're seeing this frustration. Let's just start using them. It will be God knows when, maybe dozens of years till there are these RCTs. It's hard to make a profit off something everybody's making in the gray market. And so there's not a big incentive for companies to invest in that. And the FDA isn't really interested in that. And so it's a hard time right now to see any of these actually undergoing the type of studies we would love to have. So it's not going to be something that's going to change soon. So you need to be thinking based on the data we have, am I comfortable advising or even prescribing these type of peptides for the use cases that have been shown in animal studies and other studies. And a lot of this is just about full disclosure with patients, full disclosure, and making sure you're clear and documenting, not only to protect yourself, protect the patient. Like those two people who died, who knows why that was, but making sure people understand the risks and that you're doing the most due diligence you can to procure them in a safe way. Potential advantages are what you see here on the slide, that they do seem to be much more targeted, and they affect very predictable kind of metabolic pathways. But there are these challenges. So I've pretty much covered all this in what I was just saying. I don't want to overstate it because I do want to get into the actual peptides and the clinical use cases, but I want to make sure, at an academic institution like Northwestern, that we're clear-eyed, that we're talking about these levels like 3 and 4 here for most of these. Level one, there are a few that are fully FDA approved, like the GLP-1s, Wegovy, semaglutide, tirzepatide, all those. Then there's thymosin alpha 1, which is used off label. It's FDA approved in many, many countries for hepatitis. Then there's the level 3. These are the ones that promote growth hormone. So there's some that are FDA approved, one for HIV wasting, one for children with growth hormone deficiency. And then cousins of those are being used because they have advantages over the two that are approved, but they are cousins, they're not identical. And then the weakest, but again, being used quite a bit, are this level 4. And that's mostly what our people are asking about and what we'll be talking about. So the safety risks, like I talked about, quality, sterility, labeling is in the bottle what it says. Cold chain stability. Most of these are injectable, subcutaneous injection, and have to be at a cold temperature the whole way. Has that really happened? Are you getting it from a reputable source? That route of administration, there's always risks with injections. And yes, you are manipulating to some degree whatever system you're impacting. What does that mean long term? Are you going to downregulate receptors? There are other downstream effects other than the one targeted function these peptides aim to have. They're not as many as a big like growth hormone. There aren't as many downstream effects as using growth hormone peptide as using growth hormone, but there are some. And then there are tons of overclaims. So that's the big issue, right? And then I just mentioned this about regulatory and documentation and all of that. So again, now let's just get into the actual meat and potatoes of what are we talking about? So these are the kind of categories of peptides. You'll hear some about longevity, some about healing and repair. That's where we're seeing a lot of use and frankly, the most compelling data. Energy and mitochondria, a lot of use, less compelling data. Neurologic, exciting potential, not yet ready for prime time. Immune modulating, lots of good data, like from those thymosin alpha 1 that's approved. That one's a very, very good area to look at peptides for people that truly have immune issues. And more people are using them though because we're hearing about as it relates to longevity and aging of the immune system and all of that. So some people are using them that may not really need them. And then other applications for specific scenarios. So let's start with the longevity. That's growth hormone. That's what you're hearing most about. For a while, people were using growth hormone that has theoretical risks of cancer. It is not a peptide, it's a big molecule. You're taking over the whole system. But growth hormone decreases with age, and people have noticed it is kind of the magic elixir of longevity, and yet it decreases with age. And people notice, and the reason they were using growth hormone itself years ago was you gain muscle mass, you lose body fat, your skin looks better, your brain starts working better. So there are actually positive effects of increasing growth hormone, but not in a constant way. There are negative effects of it always being up. It's produced mostly with sleep, for example, and so you don't want it up all day long. So then that led to these peptides that have helped stimulate growth hormone being produced without exogenously taking it over. And that's the key point. These growth hormone releasing hormones that are peptides are small molecules that coax the body to make more growth hormone in the same circadian pulsatile fashion it normally would. So that's what this graph is showing you is you're kind of restoring that natural pulsatile or maintaining that natural pulsatile release, just augmenting it. So that's what you'll see a lot with these growth hormone kind of promoters, that they are trying to boost growth hormone when the body would normally try to make more growth hormone. You really do not want to use exogenous growth hormone. It, again, in addition to potential cancer risk, there's pituitary shutdown, there's insulin resistance that comes as a result. And you could get shut down. I mean, that is something that the FDA are really clamping down on, that unless you're treating a child with true growth hormone deficiency, it's really not something that's recommended. So instead, this is what's being used are two types of peptides that stimulate growth hormone release. The reason there are two different types, the most obvious kind are these growth hormone releasing hormones, kind of like filling up your gas, making sure that the body will release growth hormone optimally, even maximally when it's meant to at night, when it's had a big day of working out, when blood sugar is low, because there's a big dual relationship there with growth hormone and insulin. And the main ones you'll see here are CJC 1295, sermorelin, and tesamorelin. And these increase that pulse of growth hormone. The issue is the body has a brake on that. And that's called somatostatin. So if you only did that, your body would naturally stop the efficacy pretty quickly because it would release growth somatostatin that would kind of put a brake on that increase in growth hormone. So it's coupled typically with one of these, what's called GHRP, growth hormone releasing peptide, very confusing names. Don't worry about that. Just know there's GHRH, which are the actual hormone releasers, and what's called GHRP, which are really like ghrelin agonists. They act just like ghrelin and they inhibit somatostatin, so they stop that brake on growth hormone release. So when CJC comes in to increase growth hormone, the ipamorelin allows it to do its thing. So it really like you're pumping up the system with growth hormone, you're really pushing on the gas, taking your foot off the brake by giving these GHRPs. So typically you'll see those together. The most common ones is that CJC, the first bullet on each side, that you'll see those combined together. And that's something that again hasn't been studied or published anyway in humans. A lot of anecdotal studies from humans. What does it do? It helps with boosting lean muscle mass, with losing body fat, with energy, even supposedly with brain health. And I'll show you in a minute some of the other effects of that. This is the typical dosing. You'll see about 100 micrograms of both CJC and then 100 of ipamorelin. Usually it's combined by the pharmacy into one bottle. Usually it's cycled on and off, about 5 days on, 2 days off, because there will be kind of a tachyphylaxis to it. There can be side effects of flushing. That's pretty common. Some water retention and even a histamine reaction, but that's rare. And often like a tendonitis kind of thing can happen. These are the benefits. This is why everyone's using it. And who knows? Placebo, is it real? I mean, I have had patients, like I said, I'm not prescribing it, but I have my patients using it, and I have seen dramatic benefits, I have to say. Not in everybody, absolutely not in everybody, but in some people, you have to work out. It's not going to work out for you. But if a patient is working out and doing resistance training, they will more easily gain lean muscle mass typically. They will more typically lose body fat, not like the GLP-1s. But the issue with GLP-1s we're seeing is loss of muscle mass. So that's why some people are switching over to these to maintain that lean muscle mass while losing a little bit of body fat. But you're not going to lose as much body fat as you do with tirzepatide, for example. Does help cognitive function anecdotally, and sleep quality. Actually, many people, so this is something that helps with sleep. It helps bone density. Is that direct through collagen issues? Because growth hormone we know does help promote bone density, or is it indirect through strength training, which stimulates bone? helps with healing and recovery, but there are others that do even a better job of that. But again, all of that, and there are some studies you'll see there, but most of these have been done with animals or very small human studies, and some of the human studies are from areas that don't have the best reputation for the best quality science. But again, these are cousins of actual FDA proven medications that do work to do what they want to do. So there is reason to believe that of all the categories of peptides, that are kind of in that level 3, 4 I talked about. These are some of the ones that are the most likely to actually be doing what they say. The reason we don't do the FDA approved ones is they have a lot more side effects or a lot more issues. Like sermorelin was the first one that was FDA approved. It was approved for children with growth hormone deficiency, but it's very short acting. It would require a lot of doses, and you get a lot of injection site reactions. And there is actually a prohibition on using it off label because the FDA knew that was going to be done a lot. And most things, there is no prohibition on that. So it's not used pretty much at all by adults. Tesamorelin was approved during the HIV early-ish days of seeing a lot of lipodystrophy. Remember, people in the early days of HIV on the early combinations of protease inhibitors would lose a lot of fat in their face and have what's called lipodystrophy. They gain adipose tissue in their viscera, which is the most risky for cardiovascular disease. People with HIV already have a high risk for cardiovascular disease. So this was a lifesaver. I'm also an HIV specialist. I was treating a lot of HIV patients. This was amazing. But it had a lot of side effects, but those side effects were tolerable in a patient who's wasting and has a thinning face, is embarrassed to go out, and they're gaining scary visceral adipose tissue. But it does have a lot of side effects, which is why it's not being used in this longevity market. There's edema, water retention, myalgias, arthralgias, headache. So even though it's FDA approved and potentially you could use it off label, most people don't. The last one is called MK677. It's an oral form. So you might think, well, that's great. That's like hugely advantageous. It doesn't have to be injected. Um, but it's not as powerful. It causes a lot of hunger because this really does act a lot like ghrelin, and it really increases hunger like almost insatiably for some people that have taken it. But this one has been studied in humans. Like you see here, this 2-year randomized controlled trial. There's been only 65. Again, you don't see a lot of big studies. So 65 patients. It did increase fat-free mass. And it actually did increase the growth hormone levels. And the way we measure growth hormone is often by IGF-1. So IGF-1 and growth hormone levels. But fasting glucose also increased. And there were side effects, like I said, that increased appetite, edema, muscle pain. So oftentimes it's not used for a long time because it has mood issues. You see there in the gray box. So not something used a lot, but is something some people that won't do injections will use short term if they want to. But I don't see this being used very much. What affects the response to these growth hormone? First of all, they really need to be working out if they're trying to build lean muscle mass and lose fat. So high intensity interval resistance training. Um, it helps sleep, and sleep helps growth hormone work better. So you're again working with the natural pulsation of the body, which is all dependent on deep sleep. So if they're wearing an Aura or Whoop or something, really working on improving deep sleep through decreasing screen time, decreasing alcohol, decreasing eating before bed, taking magnesium, all those things will help augment the growth hormone release, either with or without these peptides. And certainly not eating before bed because that's a big trigger of decreased growth hormone. So the intermittent fasting, but at least 3 hours before bed fasting really helps growth hormone get secreted and will interfere with the benefits of using these. What blunts it, like I said, eating late at night, a lot of stress, anything that blunts deep sleep, but especially eating a lot of before bed and chronic stress, all those are going to decrease growth hormone, and whatever decreases growth hormone will make the patient be a non-responder to these. Typically, they're dosed in the evening as well. Some people aren't given the right explanation and they're taking it in the morning, and then by the time evening comes along, which is when you want the most powerful boost of natural endogenous production, they don't have much online. Um, so you see here some of the other, if you are using this, if people are asking you about it, timing matters. You want to do it at bedtime. You want to cycle so that you don't get that desensitization. You want to do it ideally on an empty stomach because growth hormone just doesn't get promoted by the body if there's a lot of digestion happening, and really test out very low doses to start for any kind of reaction. Safety concerns, I've described pretty much all of these. There's some question about keeping that level up too high all the time. Does that actually accelerate aging? But that hasn't been borne out. There are some mouse studies suggesting that if you're using this all the time, could that accelerate other markers of aging? But that hasn't been borne out. But some people will do it 5 days on, 2 days off, and do that for a few months and then stop for a month because of this. There's no science to it. People will say they have their kind of recipe for cycling on and off, and it's just there's no science. Contraindications are really important. Obviously, pregnant or lactating, don't use any of these peptides, frankly. Uncontrolled diabetes, because there's a relationship to blood sugar control with these growth hormone secretagogues, you wouldn't use them in someone who has uncontrolled diabetes or who just isn't being monitored. If they're on insulin, they're going to need to adjust their dose most likely. If they have retinopathy, rapid changes in glucose could be a problem, so you don't give it to someone with active proliferative retinopathy. And then cancer, we just don't know. It hasn't been proven to cause cancer, but it is a growth hormone, and you are growing cells. So anybody with active or recent cancer, I would not use these in because you could be preferentially growing the cells that are most wanting to grow, which are cancer cells by definition. Monitoring them, you want to check IGF-1 levels. You can't reliably monitor growth hormone levels. So we use IGF-1 as kind of the closest surrogate marker. Again, monitor glucose and insulin because those are impacted by growth hormone. And one way to do that is the home IR, the fasting insulin, fasting glucose that helps you get a gauge of insulin resistance. I think tracking cardiovascular risk markers is smart, inflammatory markers, but mostly like what are you trying to achieve with all of these? Look at outcomes, 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 outcomes. Are you achieving, have a real goal. Don't just do it to do it. If you or someone is using them, are they trying to gain muscle mass or they're trying to lose fat? Then use a DEXA if you can, or grip strength, or even at least a tape measure of waist circumference and bicep and tricep and chest circumference or thigh. We know thigh muscle circumference is associated with longevity. So look at that. Look at heart rate variability. Look at sleep metrics. Look at some metric related to what you're trying to achieve to see if you're achieving it, and then if it makes sense to continue. Okay, I want to move on to healing and repair peptides, the second most commonly used one you'll hear about, especially something called the Wolverine stack, which is a combination typically of BPC 157 and TB 500. These again have BPC 157 has some human studies, are relatively small, but it's probably the most studied. And then TB 500, also called thymosin beta 4, has some studies, but almost all animal, no good quality human studies. GHK copper. Also, few studies in terms of its subcutaneous use, a lot of use in dermatology that's very promising, and some of that's kind of extrapolated to subcutaneous use. BPC 157 is very interesting. It stands for Body Protection Compound 157. It's a 15 amino acid peptide. Taken orally, it actually has some really good studies showing that it can help with upper digestive symptoms, and that's very safe. And that's something I think it's worth a try for people. It's somebody you're thinking of like Iberogast, which is an all natural way to treat this. That's somebody I would also consider oral BBC 157, some pretty good studies. And I know integrative gastroenterologists that use it for that, and it's very safe. That's pretty different from injecting it. And so I'm going to talk mostly about the injection part because that's what really we're talking about here. Purportedly, it has the mechanisms of action that you see here. Not all of these are absolutely proven in humans, but many of them in animals. Nitric oxide support, which is how it can help with supporting tissue repair and healing by vasodilation from nitric oxide, helping with growth factors, helping upregulate growth hormone, helping with collagen. So it's really used for healing. I mean, when I worked in LA, I'm now in New York. I worked for a long time, and there were celebrities on Dancing with the Stars that would use this to heal from injuries, and they did really well. Now, again, I wasn't doing it. I just know the doctor that was doing it, and he swore by it. And he saw these ankle sprains get better much faster when he would inject it. Typically, it would be injected subcutaneously in the area of injury. So I know people who have been spared rotator cuff surgery swearing it's because they had BPC 157 subcutaneously injected in the area. Some doctors will inject it into the tendon area. That's something that's absolutely unproven, but some people do say that works. Again, not at all proven, but been studied in animal studies. Couple human studies you'll see here. This was a 2026 review that that really only found one retrospective human study. And in this case, it was intra-articular injections. And that did have good success at about a little over half the patients reporting pain relief. And one study of that I know of, basically of oral BPC, actually, that hasn't been published, but I do know the people that did the study and really trust that they did it in a very reputable sort of way, was using 500 micrograms orally twice daily for pain, almost like an NSAID, and showed improved pain. And I hate the chronic use of NSAIDs. I think there are a lot of dangers to that. So anything that could help that has less side effects, it's worth a try, in my mind. So that's something that you can consider. That's actually available. You can order it online because it's oral. It's weird that you can just order it. So this is apparently available. The subcutaneous use, again, really very few studies in terms of human studies, but something that people are using it for, especially around musculoskeletal repair. So BPC 157, it can be used orally, subcutaneously, or intra-articular. You would never directly inject it into a painful area, but you would inject it nearby. I'm not recommending that. I'm just telling you what is done sometimes. Has a really good safety profile, but we don't know long term. Again, just like I said earlier, we don't know what the toxic dose is. There's some studies showing very high doses with no side effects. But again, we don't know. It is prohibited for professional athletes. Most of these are, but especially this one because it is purported to be so helpful with with any kind of sprain, any kind of injury. So they've specifically said this is not okay for professional athletes. It's combined with this one, TB 500, quite a bit. That's the Wolverine stack used by bodybuilders who injure themselves or are not professional, but athletes who aren't having to be aware of banned substances, like elite and high level athletes doing what's it called, high rocks, or Ironman races, like Melinda said, I'm an Ironman. Those kind of these people are doing these combos quite a bit. They feel like it really helps them recover in between aggressive workouts, even if they don't have a known injury, just the soreness gets better. And part of this is because this is based on thymosin beta 4, which has been used a lot in China and Russia and in their athletes in the past with supposed benefits. That's where this kind of got started. Again, it is not received approval from the FDA for human use, but it seems to help in different ways from BPC 157. So they seem to be synergistic, whereas BPC 157 helps with collagen. This is more anti-fibrotic. BBC 157 doesn't have direct anti-inflammation, whereas TB 500 has a lot about the immune system and inflammation. That's mostly how it works. You think of BPC 157 as really healing, soft tissue healing, and TB 500 decreasing scarring and fibrosis, inflammation, promoting stem cells, really working on kind of the immune inflammation side of things, and the repair part of it. So, together again, they're used quite a bit, very few human studies. There are a lot of, anecdotal reports and claims about everything you see on this slide. Partially because it's supposedly promotes angiogenesis. And so when you couple that with BPC 157 that supposedly promotes nitric oxide, then suddenly you have a real promising combo. You're getting more blood vessels, and then you're getting nitric oxide to help blood vessels deliver more blood. That really helps healing, helps a lot of things. But again, these are preclinical models, aka animal models. So we don't know in humans for sure. But again, something that is purported to be why we're seeing the benefits that some people say they're seeing. The protocols for this dosing you see here, 750 micrograms subcutaneous. Sometimes it's used IV. Again, this is banned by WADA, but also supposedly doesn't have side effects even at higher doses. This is that Wolverine stack. You see here people using the compression, and they're using, all sorts of fun modalities in addition to this. These are really, you're hearing this used by these, non-professional but elite level athletes who are just trying everything they can to get that advantage. So it's really, comes out of that kind of sports injury culture, not from controlled trials. I'm not poo-pooing it. I'm not saying not to use it. I'm just saying that's kind of where it's come from. You'll see it also post-surgery or to prevent surgery. People with injuries that see the orthopedist, they're told they need a surgery, they do this and they avoid surgery. I've heard story after story after story of that. So, you know, totally on you to decide, is that something worth trying in a patient who's told, look, I don't want to go under the knife. I want to do anything but. it's up to you to think about, is this worth looking into? Do your own search, your own research, something to look at for sure. Wouldn't be used forever, but it could be used for a couple of weeks to see if you're getting a benefit, and certainly used for a couple weeks after surgery to help with recovery. I've heard stories from many people about how their orthopedic surgeons or neurosurgeons were shocked at how well they were recovering 1 or 2 weeks after surgery through using this. The last one that's kind of used in this same family is called GHK copper. We hear about this a lot from dermatologic products, and it's actually well studied for that. It's used for that. I know dermatologists actually do think it's something good for that. So I'm not going to speak to that. You can look that up on your own. And it's something that does seem to be very helpful for skin, for kind of regeneration of skin. Um, but what we're talking about here is because it helps with collagen. As you see, it upregulates many genes for collagen production. So then the thinking was, well, can it also help with wound repair, with tissue repair? It's promoting angiogenesis, promoting collagen formation. It's anti-inflammatory, it's anti-fibrotic. You see all these biological actions. So in addition to skin regeneration, could it be helpful for all these others? And so it is used for some of these things. Again, not well studied for these, but something that is used a lot in addition, sometimes combined with the BPC 157 and the TB 500 as a kind of turbo Wolverine stack or whatever it might be called. But this is one that, I'm pretty cautious about. However, I think topically, talk to your dermatologist about it. There's a lot of excitement about using it in creams and serums. The other issue with this is there are lots more injection site reactions that causes burning, and like 25% of people use it. So I have heard of people using it and they just couldn't tolerate it. So nowadays you'll see nasal sprays, troches, which are like, lozenges that dissolve under your tongue, and people swear that they've measured some levels of whatever they would even measure. Again, no real proof to that, so I'd be very wary of that. But that is claims that you'll see other delivery devices of this more than many others because of that burning with injection. The other thing is it is a copper base, so you got to be careful with Wilson's disease or other copper issues. The burning I mentioned. In addition to the burning, people get these little nodules at the site of injections. That's another reason they're coming up with these kind of alternative forms like the lozenges, the troches from it. So with this, I would say be very, very, very wary of this, but topically look into it. Now let's jump to the energy mitochondrial peptides, the next biggest category. We talked about longevity, we talked about healing, repair. Now let's talk about people using peptides for kind of energy, mitochondrial function, feeling younger, feeling more energetic. We're seeing quite a bit there, and there's a reason for that. We know that as we age, we get more energy. Our mitochondria do decline, and basically, what happens in terms of functioning, remember Krebs cycle, right? And remember ATP production and all of that. That happens on the inner membranes of the mitochondria. I'm going like this because that flattens, right? So you need all of these inner membranes called the cristae. That's where that is all happening, where ATP is being produced through that electron chain reaction, starting with NAD, getting to ATP. And what happens is those inner cristae flatten out as we age, and that's what then leads to less availability of basically the surfaces to do that electron transport and to produce ATP. So we absolutely see a decrease in mitochondrial efficiency as we age. So there's a lot of research into how do we counter that. And what do we do? And do we take things? And we're hearing a lot about all different supplements that help with mitochondrial efficiency. So in addition to the supplements, there are peptides. So the most common one we see is this MOTS-C, mitochondrial open reading frame of the 12S RNA type C. It's a 16 amino acid peptide. You can read there, but it does activate AMPK signaling pathways, enhances glucose uptake, improves insulin sensitivity. It actually does promote mitochondrial biogenesis. All of this based on preclinical, aka animal studies. We don't know much of this from human studies, but some small human studies suggest, these are like preliminary pre-RCT type studies, suggest that they improve longevity, cognitive resilient athletic performance. This is kind of the hot peptide, I'd say, right now, beyond the growth hormone peptides. A lot of people are hearing about this and trying it and excited about it. Again, and you see some studies there that you can look into for sure about, how it affects muscle and fat metabolism. And so it is promising, but again, we don't have a lot of data on these. There's no established human standard dosing even. These are the doses used in rodents that are then extrapolated to what should be used in humans. There are some safety concerns because it can cause like an immune response, and there's higher reaction rate to this one than to others. This one is a little different. All the others are actually very similar to natural things our body produces. MOTS is there isn't a MOTS in the body that I know of anyway. So this is one that is very promising. We're not really sure. Lots of claims. We'll see, but you'll be hearing a lot about this. The other one that we hear for mitochondrial therapy, a little less than MOTS, but is gaining kind of traction in this world, is SS31. It's partially gotten to like rise up so much in prominence because it actually has been FDA approved for something called Barth syndrome. And so therefore it is being used off label to help. And Barr syndrome is when you have a genetic issue with mitochondrial functioning. So this one selectively targets and binds to something called cardiolipin on that inner mitochondrial membrane and stabilizes that structure. Remember, I said the structure flattens out. This helps stabilize that curvy structure to optimize that electron transport, produce or boost ATP production. So this we're going to see used more and more. This was only very recently approved, and so I think we're going to be seeing this, and we'll see. Maybe the FDA will prohibit off-label use of it. I don't know, but it's something that we can feel more confident that at least it's safe. We know general doses that are appropriate. It has actual been shown to be beneficial to do what it says it does. Not everything it says it does, because there are a lot of claims, but at least around mitochondrial functioning. It's being studied in things like ischemia reperfusion protection after somebody, it comes off of a bypass or other times when they've had ischemia. And it supposedly has a bunch of multiple organ benefits, especially looking at for heart function and CHF and post-MI issues. So, that's something to really keep an eye out, but that has not been proven. But because so much of that damage post ischemia is happening because the mitochondria aren't functioning again and creating ATP. That's why it's being used in all of these applications you see here on this slide. Um, some people recommend using this along with thymosin alpha 1, which is also helps the immune system. That's the one that is FDA approved, or not, it is approved for hepatitis treatment in many countries. Some people combine those in like a yearly reboot in like the spring as soon as it starts, which you'll see soon, especially in Chicago, hopefully soonish. Um, then they'll still use these in combination where they'll get the immune system regenerated after having been, fighting off all these upper respiratory infections all winter, and then the SS31 comes in and helps with the mitochondria kind of coming back online after having been beaten down by working so hard all winter. No proof to that, but you do see this quite a bit. All right, and I know we don't have that much time, and I want to have some time for questions. So a couple more what I call chapters here to cover. That now we're getting a little more into the weeds that you don't hear quite as much about, but you hear some. So just to be aware. So brain, right? We're seeing more and more. I know in my practice, the number one issue is how do I keep my brain sharp? How do I prevent early cognitive decline? I can do a p-tau 181 or 217 test and know that I'm okay, but how will I know I stay okay, or know that I'm not okay and it's elevated and I could get Alzheimer's in 10 years? What do I do? So we're seeing a lot of people really concerned. CMAX we used a lot. Russia, a lot of the studies are out of Russia, not necessarily the best quality science that we're seeing from them, especially around the peptides. A lot of these are animal, rat, rodent studies, but lots of claims about it helping brain health through increasing brain-derived neurotrophic factor, right? BDNF, and also nerve growth factor expression, supporting neuroplasticity. And that's what it's all about, right? That's what we're all trying to do is support neuroplasticity and support transcription for that. And use our sleep habits for that, our intermittent fasting for that, our exercise, our mindfulness. So we're all about that. Absolutely. Does CMAX do that? lots of anecdotal and rodent studies and some questionable human studies say it does. Also supposedly helps promote gene expression that promotes cerebral health for things like the VEGF, and supposedly has been studied for cognitive enhancement, especially around attention and tests of attention, but very limited quality RCT data. This is one where there is RCT data. It's just questionable the quality of that RCT data. Um, so something to look at because we don't have a lot of options. So again, this is like if you have somebody that has a high p-tau and maybe an MRI finding of early Alzheimer's, you don't want to maybe put them on one of the new infusion medications that has a lot of side effects. There are newer ones coming out in a year. What do you want to do in the meantime? Maybe think about it. That's up to you. Um, the cousin of it is called Selenk. So this last one was Cmax. This is Selenk. You'll see them used kind of together. Selenk is anti-anxiety, kind of without Xanax. So it's a Russian peptide again with anxiolytic and nootropic properties. It appears to modulate anxiety without causing sedation. It's not addictive. It does seem to be effective. It is subcutaneous, so this is not a pill. So this is for someone that would have chronic anxiety, especially like social phobias, something that's always coming up and interfering with their quality of life. Something to think about, again, very limited Western clinical data. And I certainly wouldn't use it alongside the benzos, like Xanax and Valium and all those. Or even if they're on any psych med, I would really check with a pharmacologist about that or a psychopharmacologist, but it's something to have knowledge of. Immune enhancing peptide. I've mentioned these a couple times. I told you TB500 has some of that. And then the big one's the thymosin alpha 1 that is approved in many countries for hepatitis. It has been proven to actually help the immune system in these ways. Basically, it's a synthetic version of what naturally gets produced by our thymus gland, which, as we know, involutes as we age. And so it helps replace some of that thymus gland function that decreases very significantly. Even just by age 20, it starts to decrease. And that promotes T cell differentiation, which promotes better immune responses, promotes immune balance, has anti-inflammatory effects, is antiviral, supposedly anti-cancer. You see it here. It's approved in certain markets for chronic Hep B and C, also to boost vaccine sometimes for those. It's being used again, people who are kind of desperate, like Lyme disease, EBV, chronic fatigue, autoimmune issues, trying to balance, because it's not just immune enhancing, it's really immune modulating and balancing. So some people find it helps with immune function. Certainly the merging field that we see it in our kind of longevity space is age-related immune senescence. There's so much talk about immune aging as a huge component of overall aging. So this is something we're seeing more and more about. These are some of the dosing you'll see for a chronic infection. You'll see it used either sub-Q either weekly, twice weekly, daily. There's really all different doses. It can all also have skin reactions, but usually not bad. And it's really important that if somebody has a real infection, you don't just use this, you treat the infection, but this could potentially augment that. Um, the last one I want to talk about, it's kind of a fun one because you might have heard about it, and this is FDA approved for hypoactive sexual disorder called PT141. And so this you will see out there. This is legit. This works. This is approved, but it does have side effects. So this absolutely helps with sex drive. It helps. It's approved for women with HSDD. I don't think it's approved for men. It works on the brain, not peripherally, so it doesn't people can use it with the PDE5 inhibitors like Cialis or Viagra because it doesn't directly treat erections, but it indirectly treats erections because it increases libido and increases horniness and increases, desire, which can then stimulate erections unless there's a real issue with blood flow and with creating erections, and you would need to couple it with a PDE5 inhibitor. So if somebody is trying PDE5 inhibitor, it doesn't work. Sometimes this coupled with it will work because some of that might be coming from kind of central mechanisms. It does cause nausea in a lot of people, almost half the people. And there's a black box warning on blood pressure elevation with it. Typically, it's an injection, but you can also get nasal versions that actually work well, and even troche versions. But that's the worst for blood pressure, those oral versions. So you got to be really careful. Don't give it to somebody with high blood pressure. Document blood pressure issues if you're using it. The safest way is actually sub-Q, but that's not as convenient. So you'll see these other versions. People get it online. And this actually does work. So just be aware of those side effects and that black box warning. Good. I have like 10 minutes for questions. Just the last slide here, just to kind of give you the overview. Actually, a couple more quick slides is This is what we've talked about. Longevity, we talked about primarily the growth hormone receptor, the growth hormone boosting hormone, CJC 1295, coupled with one that blocks that somatostatin break, ipamorelin being the chief one used. Talked about healing and repair, the Wolverine stack, BPC 157 with TB 500 plus minus GHK copper. We talked about overall energy, mitochondrial function with MOTS-C, more and more now SS31 since it's been approved for BART syndrome. The Neurologic, CMAX and Solank. CMAX more for kind of cognitive function in general, Solank more anxiety. Thymosin alpha 1 as that immune modulator, helping with the immune system, and then PT 141 for libido and sexual desire. And you see there the evidence level pretty low for most of these, other than the ones that are FDA approved, and the risks with those. Again, just to reiterate, if you're going to think about using these, really you want to get from quality manufacturers, quality pharmacies, document that this is officially research only, or you're going to compound it yourself, verify that cold chain, get it from USP, kind of level type place. Be very wary of anywhere that you don't really trust, and document discussion with patients and what the warnings are. Key takeaways here, we know these are short chain amino acids that are relatively safe, small molecules. Just think of them as signaling molecules, that there's quite a limitation in terms of human clinical trials. There are what we'll hear as preclinical trials, which is usually animal studies or just anecdotal reports. There are lots of surrogate endpoints. We don't really have a lot of outcome studies. We don't know that animal preclinical trials translate to human trials. We don't know if the dosing translates. So all these are limitations we're not sure about. There are a lot of claims. Certainly some of these claims are probably real, especially if we can have a mechanistic explanation, but some of them are really far-fetched. And that's what you see on TikTok that I was showing you and these other things. Um, and in the future, we really want to be looking at, yes, how do we operate and being ahead of the curve with our patients? How do we offer them things that have a safety profile that is tolerable, that the benefit is proportionate, in a way that we can really verify as much as we can, but how do we move the science along? So collecting outcomes as much as you can if you are using these. Try and build that database of knowledge. If there are issues, identify those issues. Let's get that out there. But I love this idea, one I'll just leave you with, of how do we work with the body instead of just imposing on the body? That's what we do when I talk about majoring in the majors with lifestyle. But yes, there are other things we can do too to augment things that are slowing down with age, right? I use testosterone in my patients. Could I just, if there are ways to boost testosterone production naturally, I'd much rather do that. And so sometimes I'll use HCG or clomiphene for that. I love doing that. That's much more in sync with the body's natural rhythms. Can you use that? That's the seasonal thing. I kind of said it's people do this once a year immune reset, but that's not a terrible thing. We do change with the seasons. Could we work more naturally with the body? So the big take home for me of peptides, the exciting part is just that message of how do we work with the body instead of imposing on the body, and what lessons can we take from that? Because the future is really being much more in sync with the body and precision around a targeted function as opposed to a whole big pathway. That is it. A few minutes for questions.
Oh, it's a whirlwind of peptides.
It is. Sorry.
Um, so no, it was amazing. So people, please feel free to pop questions into the Q&A section, and I'm happy to field them with Dr. Myles. I had two questions. One, so I know you mentioned that the one that's used more for musculoskeletal injury and uh, gastric issues is available orally over the counter. The other one that I wasn't familiar with, the Solank one, it's a nasal spray. I just looked it up. You can order one of those on Amazon. So,
That's
I
scary. I
mean,
don't know the quality of that. That I don't
no,
know.
no, no, right. But I'm saying, like, so I feel like we have this interesting mixed message of these are safe enough that, or they're almost getting regulated like dietary supplements, right? That they're
Right,
not,
right.
they're regulated like a dietary supplement when they are available orally or intranasally or sublingually. But then their injections, you require a prescription from a physician. they are under, obviously that's more invasive, they're under more scrutiny. And yet and like sort of the parallel for me is we're seeing the GLP-1s, you needed to inject them. Now all of a sudden, and but compounding pharmacies were doing sublingual and oral forms. Now there is an oral FDA approved. So to me, it just seems like a real mess of like, well, are they safe enough to be dietary supplements and regulated as
Right.
dietary supplements, or are they prescriptions that we need a lot of clinical studies on and need, should be pushing forward for FDA approval? And yeah, so
Yeah.
yeah,
I think it's just moved so much faster than the FDA. I don't think they should be available, even the oral formulations, like a supplement, honestly. Like BPC 157 is, I don't know why it is. It probably shouldn't be. I mean, because it's not just a supplement. It is a peptide. It is much more analogous to a medicine, to a pharmaceutical, but it is. I don't know why Selang's available on Amazon. I mean, it shouldn't be, frankly. But yeah, I think it's just that the market is much faster than the regulations and the regulatory people.
right, something will happen soon. And
Yeah.
you mentioned that some of the peptides were ghrelin. Uh, are there leptin really? Because I think we
Oh,
see
good question. Yeah.
because we
No.
think of one as the satiety, one as the hunger. So
Right.
ghrelin, the hunger,
Right.
leptin, the satiety. But what I see in
Yeah.
more of my patients is analogous to insulin resistance or people having low leptin also and leptin resistance. And so are
Yeah. Yeah.
and I know that there is something maybe in HIV that's a leptin analog, but are you aware of that being
I'm
used at
not.
all? Okay.
No, I'm not. Yeah.
Okay. Um, so one of our physicians says, what do you recommend as a good way to follow progress in this field of longevity medicine?
I mean, you can take courses. There are courses in this. There are courses through, I think, something called, and I'm not even sure, like the International Peptide Society, maybe. They used to exist. I don't know if they still do. There's some through A4M where I teach sometimes, not on this, on men's health. They have a course on peptides. I would look for a course that is reputable. And then typically with those courses, I'll give you updates, even if you're a graduate of that course.
hmm Okay, great. Um, I'm going to defer the question on testosterone for women since we're focused on peptides today. So, I think that is a separate issue. Um, Um, are you aware of clinical trials that are ongoing now that are, government funded, that are clinical trials? Because, like you said, it sounds like the most of these are animal studies. Um,
Hmm.
and doctors or practitioners are prescribing them as research. But are you familiar? Like, is this like the GLP-1s? Are we going to just be seeing these as prescription options, do you think?
I don't hear. I've asked the scientists. That's why I said that at the beginning, like in this FDA world, because in anticipation of this, I was asking which of these are being studied, which of these we're going to get to data. And they're like, the main head of I had all these scientists I work with, the head of all the scientists was like, none of them, none of them. I mean, they were maybe a few years ago starting to be studied. And then when this whole regulatory change happened, 2023, 24, everything kind of stopped because there's not a line of sight into them actually being able to be produced. So why study
Okay.
something that you couldn't really produce? So I don't know of any. I mean, like I said, there are these privately funded trials of BPC 157. That's the biggest one.
Yeah.
And MOTS-C, there's some things starting because that's such an anti-aging longevity, but that may slow down
Right.
now that there's the SS31. So yeah,
Right. Right.
I'm not
Right.
sure.
Yeah. 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 It's just interesting the way that some of them go through and get FDA approval, and then others that have promise just seem to live
Yeah.
in this netherworld, which I think leading to the TikTok fake docs promoting
Yes.
them, as
Yes.
opposed to them
Exactly.
if they have a potential limit, real benefit, we should be studying them.
Yes.
Um, all right, well, I know we're at time, so thank you so much for joining us today. For people who are on the recording, will be sent out as a follow-up link if you registered, and will also be on the website that I put in the chat, both Osher and IFAM sites will be hosting this. So I know there was a lot of information. People probably want to go back and look at the slides and really write down notes. I know I was trying to keep notes. So yeah, thanks so much for being here.
My pleasure. Thank you. I know it was a lot.
Yeah,
Hopefully, just gave you few food
no,
for
it's a
thought.
great. And our next one is on psychedelics with Dr. Mariella Wood, which will be an amazing talk also. So thanks, everyone. Bye
Great.
bye.